Hi everyone, and welcome to the PhysiQuip Academy for this webinar on the importance of ultrasound with interventions around the knee with Dr. Harjinder Singh. So Harjinder is going to be doing a short presentation, and then we'll go into some Q&A, starting with some pre-submitted questions that we've received. And then if you're listening live, please feel free to submit any questions that you've got into the Q&A tab, and we'll answer those as best we can. And with that, I will hand over to Harjinder to get started. Thank you.
Thanks, Kyle. Yeah, that's a cozy group we've got here. So thank you for PhysiCheat for inviting me to give this short presentation, just to give you a flavour of why it's important to use ultrasound and ultrasound guidance with interventions around the knee. I think a lot of times people use landmark guided, and I had a real life example today that I'll start off with. Where I had a professional footballer come to see me, wanted an ultrasound guided injection because a landmark guided injection that they previously had was very painful. So, and that's just from today. So, but I'll tell you a little bit about myself, and then we'll sort of get into the nitty gritty. So, I work in the sports medicine department in Leicester, and I do a guided interventional clinic every week. So I do lots of different procedures, and my colleagues tend to refer into me as well. So I tend to do all the injections within the department, and they're all guided. I can't remember the last time I did a landmark guided injection. I think that's a bit kinder than saying blind. I think saying blind to a patient, a blind injection gives a different connotation. So private practice, I had a private clinic this morning. I did 3 guided injections, one on a professional footballer, somebody else into a shoulder joint, a hydrodilatation, and then a tendon procedure as well. So I tend to do a steady stream privately as well, and certainly my colleagues refer into me. From a sporting context, I work at Leicestershire Cricket. They're unfortunately away in Cyprus at the moment. I've just heard the news that there's going to be a aircraft carrier going to Cyprus, with everything that's going on. So I work with GB Boxing as well. So I was only meeting this morning, and I do work with some professional boxers. And I think the expectation there is that, you perform all the injections under guidance with both sets of players. I work with PGMOL, so I'll be there tomorrow in camp. I look after their medicine side of things, not their decision making. So I have no influence on that. And then I work with various football clubs locally within the Midlands. So one of the players that I saw today was from a local club. So certainly keeps me honest and busy there. My areas of interest is the use of ultrasound, but both interventional and diagnostic. Really important, the governance of the use of ultrasound, and that's why we've put this together, and we're going to put some courses on as well to give you a flavour of how I think it's a journey with ultrasound, and it is a learning curve. I also like look at the latest non-operative interventional treatments, and have an interest in orthobiologics and regenerative medicine. But for the purpose of this, it's the top 2. So I'm an ultrasound trainer for PhysiCheat, and I also do some work for Arthrex as a trainer. And we use the Alpinion machine there as well. So that's the machine that PhysiCheat also use. So I think it works well with that. So my old ultrasound training, I've done an accredited PG cert in musculoskeletal ultrasound. I did that from the AECC Bournemouth. I've been a trainer for ACP, which is a type of PRP. Got delayed a little bit because of COVID, and there wasn't any face-to-face work. So I've been doing that, and I go across to Germany once or twice a year and occasionally teach at the facility in Solihull as well. So I periodically do some teaching at the AEC in Bournemouth. That's under change at the moment. But I teach locally in the NHS, teach the resident doctors, do certain other teaching with other allied healthcare professionals as well. And I like to audit my practice with peer review, both in the NHS. So try and get all my images on packs and then get radiologists to review the images. I tend to have the same radiology rights as a consultant radiologist at the private hospitals, but they can then interrogate my images as well and see what I'm doing. And I think it's good practice to probably have 10% of all the ultrasounds that you do are peer reviewed. Often that's not always possible, but to get some feedback from colleagues, because I think the difficulty is that there's no real formal accreditation in place currently, and you can just start. Whoops, yeah, you can just you start scanning and performing interventions without any training or qualifications. And if you're a lone practitioner, I think you need to have some peer support just as a sense check. I think that's with everything, certainly in the world of sport where practitioners can work in isolation. That can be dangerous because you have no sense check or somebody to sort of cross-reference with. And I think it's the same with ultrasound. And there isn't an appraisal or audit of clinical practice. I know the faculty, sport and exercise medicine, did put something together, but it didn't really work. And I think perhaps the College of Sport and Exercise Medicine may look at that in the future. I tend to sort of keep all my images for scrutiny. I think from a medico-legal perspective, it's pretty good. And if you have a high-profile athlete or their teams today, I had a physiotherapist with me, and he's also doing ultrasound, so he could see exactly what I was doing, and we've kept the images, sent the report. Anybody in the network can look at those images and comment on them. So, but I think from a medical legal perspective, keeping the images are really useful. But you've got to have the baseline competency as well. So why do we want to use ultrasound? I mean, there's lots of reasons. Um, I think it's certainly from an interventional perspective, you can, whatever you're injecting, you can get it into the area of pathology. So there's one less confounder to recovery potentially. There's a few studies that I'm going to just go drill into that show that clinical outcomes, uh, healing rates, and function between ultrasound guided groups and the blind. And I've used blind there, I should have used landmark. Show superior outcomes with ultrasound. So I think the outcome. You can avoid critical structures, and that reduces the risk. It doesn't eliminate it. I mean, somebody might say that there might be a placebo effect, but I think this placebo effect accounts for 30 to 40% of what we do. But I think having the ultrasound, for me, there's one less confounder in recovery. With patients who come for interventions, there can be lots of reasons why they're not recovering, and the injection's only part of what they need from a rehabilitation perspective.
Sure.
So the benefits of just to go down further, I think for joints, you'd be surprised how difficult it is to get into a knee joint. And once you've aspirated a knee joint, you know where your needle is. So, we've talked about the risks, the reduced risk of iatrogenic damage, nerve, blood vessels, tendon. There is the quads tendon and certainly the fat pad that you have to avoid when you're injecting around the knee through the suprapatellar approach. Real-time imaging, as I've alluded to, if you aspirate a knee, where is your needle at the end of the aspiration? Because that will have moved. Are you in the structure? You're in the recess still? And sometimes the needle moves more than you realize. Some of the finer needles, certainly if you're doing a deep injection, they will move. I did a hydrodilatation of the shoulder today, and just with the injectate going in, there's quite a lot of fluid that can move the needle. So you're constantly checking and rechecking that you're in the position that you need to be. Yeah, needle visualization. So, taking images. So I have, I always have an assistant that presses the image where and captures where the needle is. So I think from a medical legal perspective, that certainly um, helps. I think athletes now expect injections to be done under ultrasound guidance, and I think that's the least you should expect. I think you're getting optimal out therapeutic results. We hope part of a multimodal approach. Though I appreciate that better clinical outcomes, and I'll show you some studies about that. And I think patient safety and comfort. Certainly, anecdote from today again. The athlete, the footballer that came in today, you know, didn't feel anything. I mean, with the procedure I undertook today, you don't use local anaesthetic, so it was without local anaesthetic into the knee, and it's more comfortable than local anaesthetic, which was done under landmark guidance. Um, so, so that's a real living example of it. Clinically guided landmark blind injections. The limitations, obviously, if you're in a primary care setting and you're not trained with ultrasound, still has a utility, but you can't always know where you're injecting. You can't see the needle, so you are going by landmarks and experience. Potential for more damage if you can't see the needle tip, and because the injectate isn't in the right place, it's no brainer that it might not be as successful. And some of these treatments that I undertake with orthobiologic or regenerative medicine, that they're pretty expensive treatments. So you want to have it in the right place, um, to get that out, the outcome, which isn't guaranteed, but that, as I said, one less confounder. So you're trying to help the patient. Obviously, there is a cost involved with ultrasound versus landmark guided. People know this is from a study. 25% of landmark guided knee injections aren't in the right place, so they're not intra-articular. So, one in four may not be in the right place, so they're probably not going to have an effect. The caveat is that the more experienced you are as a professional, if a knee surgeon's doing it, that might go down to about 10%. So I appreciate if there's anybody orthopedic on the group, they may just argue back with me there. So, as I said, this is going to show you a little bit of evidence of what studies that have shown why ultrasound guidance is useful. So we've got the SSR study here, a consensus statement from a Delphi consensus, and that's when lots of statements are made and they go through the great and good and they drill down on what they agree on. So ultrasounds strongly recommended for intra-articular injections of for patellar tendinopathy and intra-articular injection of PRP. Baker's cyst aspiration, in some ways that's a no-brainer when you've got your popliteal artery close by. Pezanthrine bursitis, can be difficult to see even with ultrasound. But also, with any of the regenerative medicine products, they've suggested you should be using ultrasound for some of the reasons that I've suggested. So that's a recent consensus statement from just 2022. So a few more studies. This is a smaller study, 185 knees. Don't know quite what happened then. So patient-reported outcomes improved at 6 months following ultrasound-guided injection of PRP. They said that cartilage thickness had improved and less synovial hyperplasia and less neovascularity. I'd take that with a pinch of salt. But, again, 2021. So, a good amount, 185, which is, a small study. Then a systematic review of about 1,400 patients and 1,315 knees. So it was 7 studies, direct comparison between ultrasound guided and blind injections. The ultrasound guided injections were more accurate compared to blind injections in every study. They didn't look at the patient reported outcomes. But again, a systematic review, within the last 5 years, 12 studies. So a good amount to say that ultrasound is more accurate. And just a little bit about the sonoanatomy here. So this is in transverse. Let me just move. Oh, sorry, this is in longitudinal, beg your pardon. So we've got the patella there, quads tendon here, suprapatellar fat pad. That's the sort of S-shaped suprapatellar recess that you aim for if there is an effusion. And this is the prefemoral fat pad. So that's longitudinal, but I tend to first find it longitudinally and then go into transverse. So then you've got your quads tendon there, femur there, prefemoral fat pad, needle coming in there, and that's a small effusion. And yeah, that's very much like, wasn't the image from this morning, but I'd certainly have a very similar image from that. With interventions around the knee, a lot of it will be suprapatellar. I do some tendon procedures, so patella tendon, I may inject into that, quads tendon, occasionally into the collateral ligaments for acute injury as well, iliotibial band, bursitis, Baker's cyst, aspiration. So they tend to be the common ones. Very occasionally injections into the superior tib fib joint, more of a diagnostic thing. So they seem to be the ones I have one patient that I do a nerve block, a saphenous nerve block for medial knee pain, but these are the basics. But they're some of the things that I do with injections around the knee. So this is just the patella tendon in longitudinal section. This is the tibial tubercle tendon coming over here, nice fibro pattern, and top end of the patella, inferior pole of the patella. There's a little bit of fluid there, normally in the patella bursa, which is within normal limits. Very occasionally that can be symptomatic, so you can inject into that. Sometimes you get a reactivation of the Osgood-Schlatter, so you get a tendinopathy with that. So very occasionally around the tibial tubercle, you can needle that or inject into that. So this is the tendon. It hasn't come across that well, but that's in transverse section, and I'll show you, there will be a picture later on, which is the needle, which is intratendinous when you do, for example, a PRP injection. Or in my NHS practice, we do autologous blood injection, which is non-centrifuge blood with decent results. So some of you might have thought, what do you do if you can't see that suprapatellar recess? Then there is a medial patellofemoral approach. I tend to only use that when you can't see the recess. 9 times out of 10 you can, probably even more than that. But you've got to avoid the saphenous nerve. That is a sensory nerve, so and it goes medial to the knee, and you can see it on ultrasound. The needle is obliqued in this direction, so it's the needle isn't. You can visualize it, but it's not parallel to the probe, so you won't see it quite as well. And there shouldn't be any resistance to it. So that's another approach that you can certainly go through. The classical eye of the knee is difficult to visualize. You can visualize it, and occasionally patients say to me, I want it through the front of the knee, and you can follow the needle, but often that is out of plane, or you have to really oblique it. But it's not a normal an approach, because you can be in the fat pad, and that's probably why you go this way, or the suprapatellar recess. So we're just going to go through a few clinical examples. So I mentioned that I do some ligamentous treatments. So this is a lateral collateral ligament high grade injury. Went to see a surgeon, because it's an isolated injury, suggested serial PRP injections. So that was at week 1. You can see it's quite hypoechoic. Probably some fibre integrity there, but you can see almost that stump there. So at week 2, this is with the needle in place there. That's the injectate going in there. And then week 3, you can see that there is a bit more bridging, and that is a mixed echoic signal. You still see the stump, but that's within 3 weeks, and that tissue will mature further. And this player made a non-eventful recovery and return to play. So that's what this is what this is the longitudinal view of PRP into the patellar tendon, and it is an intratendinous procedure. I tend to go more transverse because you get an area of cystic degeneration in the tendon that you can really target with transverse. And we had quite a good debate when I was in Germany recently, teaching should you go longitudinal or transverse with this, and there wasn't a universal view. What you want to do is get that injectate where it needs to go, and whether you go transverse or longitudinal, there is controlled damage to the tendon, so that's you want to get the injectate to where it goes. So this is my approach, more of a transverse approach, and that is again intratendinous in the tendon. Tend to inject on the way out, needle in, fenestrate, inject on the way out. And these are a series of images, probably from a few weeks ago. Somebody had a quadriceps tendinopathy, and this is the longitudinal view. Probably hasn't come up as well, and you can see that the needle and the top two transverse images there, and you do pepper the area where the pathology is. So that's longitudinal. See where the pathology is, and that hyperechoic area is where the tendinopathy is. So again, Neo-A, pretty standard into the recess. If you have an effusion, drain that, recheck, and then put the injectate, whether that's steroid or more local anaesthetic, whether it's hyaluronic acid, PRP, etc. So, it's a slight whistle-stop tour there of why it's important to use ultrasound around the knee. And, this is, that's just showing you and showcasing things. Certainly the first point, if you're starting off on your journey, is to do a course, then what normal structures are like, and then move on to intervention and get that all accredited. So pretty quick, Kyle. I think we've come to the end, haven't we? So yeah, happy to take questions, and then my contact details if anybody wants to contact me afterwards. So
of course. Yeah, it's probably worth mentioning the course as well, isn't it? On the 13th.
yeah, yeah. So we're in London. So Isokinetic. There's a course there where there's going to be hands-on practical session about ultrasound around the knee. So it'll be going through all the major structures that you need to see. You start off with the suprapatellar recess, and then you're looking at medial collateral ligament, lateral collateral ligament, ITB, patellar tendon, quads tendon, back of the knee, looking at for Baker's cyst, also looking at the medial hamstring tendons and medial gastroc as well. Looking at a systematic approach around the knee to see why ultrasound is so useful. But I acknowledge there can be limitations. So I think it's well worth having a look, and I think Kyle can send you details if need be regarding
Of
that.
course. Yeah, sure. If you head over to the www.physiequip.com website, there's an events page, And if you just head over to the events section, you should be able to sign up there. And there's a whole list of events there as well that you could sign up to if they're of interest. But, just want to say thank you. That was really good. Then there was some really good insights there, Harjinder. So thank you. Um, I do have some pre-submitted questions, if that's okay. And if there's anybody online who has any questions that they'd like to ask, just feel free to put them in the Q&A function below. But if it's okay, I've got some anonymous ones here, if that's okay. And the first one is, how do I get more experience?
So yeah, I mean, experience. I think coming on courses, but also doing a PG cert or an equivalent will be useful, and being on an accredited PG cert. Certainly, from a doctor perspective, to be able to independently scan, you probably need to get to the PG cert level. But it is also then knowing that's just the start of the journey. Um, I did my PG cert several years ago, and I put my certificate up there. When did I do that? 2015. But it still took me 2 or 3 years after that to really get confident. And then having a mentor as well can help. And it's very difficult because people are in clinics, and if you're working privately, it can be difficult. Historically, the AECC in Bournemouth used to do. You could buy sessions where they bring patients in, and you could get a good logbook of experience and see pathology.
Right.
Masterclasses, they called it. I'm not sure that they do that anymore, and whether any of the other PG certs do that. But you've got to get you've got to scan regularly, get used to it, get that fine motor control going. Getting your eye in. I remember the first time when I was handed an ultrasound in the middle of a clinic. I thought I've got to grip it as hard as possible and place it on the patient as hard as possible. Um, but yeah, it is a journey. Some people have got great visuospatial skills. Other people have to work at it, but you have to continually work at it. But also know your limitations.
Amazing. Really good answer. Thank you. Another question is, how cost effective is ultrasound in comparison to other image modalities?
So, I think if you've got your own machine, it depends what sort of facility you're using it. If you're in a sporting club, I think it has a utility of a screening tool. Certainly, for the knee, you can look at ligaments. If there's a significant effusion, but you think, well, I might need to look at that in more detail, um, and then go for an MRI. Cost effective cost effectiveness of it. It is cheaper than MRIs. More expensive than an X-ray, but an X-ray has limited function. Great for osteoarthritis, but make sure you do a weight-bearing X-ray for that. But I think it gives you, it's an extension of your clinical skills. So I tend to use it, as part of a standard assessment. Luckily enough, in most settings that I'm in, I have an ultrasound available to me. Um, and a plug for Physique. Got a great machine at the UK Sports Institute in Sheffield, which has been set up by Dom. Dom set it up for me to my preset, so I'm lucky enough to do that. So certainly, I think it is a cost-effective treatment and modality, imaging modality, and it's got the added bonus of there's no ionizing radiation, so better than X-ray in some ways. Doesn't have you can't look at the deeper structures, but you need to know what your limitations are with an ultrasound as well.
Of course, amazing. Thank you. And lastly, I've been asked, what are the limitations of ultrasound?
Yeah, well, I think probably going on to that, you can't look at menisci, deeper structures within the knee, an ACL, you're not going to be able to see that, despite colleagues who think they can. PCL, you can't see. So I think, for something superficial, it's great, but it's all about your clinical reasoning. So you need to know what your mechanisms of injury is, what's your clinical reasoning, and what's your differential diagnosis, and then if an ultrasound is an appropriate way of investigating, then you would do that. But I acknowledge, if you've got a meniscal injury or something like an ACL or PCL, it's not going to be the way forward. So it is knowing those limitations as well.
Amazing, thank you. I can't see any questions in the Q&A from anybody online. Just give it a second. Is there anybody online that has any questions for Harjinder just whilst we're here? Give it a second. Don't be shy. No problem. I don't think there's any further questions. So I'll just double check and make sure. No, I don't think there is. So yeah, with that, then obviously I just want to say thank you to everyone for joining us. Thank you, Harjinder, for the presentation. I thought it was brilliant. Following on from today's session, if everyone is going to receive a link to the webinar recording, especially for those who couldn't make it. And if you want to get in touch with us about any of the technology we've discussed today or the education that we provide, please drop an email to info@physequip.com. But if there's nothing from anybody else, then thank you for joining us, and I hope you all have a nice evening.